Good morning. Thank you all for being here today. It is my honor to do this conference, and I do hope to continue to do it as long as I can. Thank you, Stephanie, and thanks for all the supporting staff at the Scleroderma Foundation. Thank you for being here today, and we will go over an overview of Scleroderma presentation, as well as updates in terms of treatments and possible clinical trials. This is my disclosure. I have nothing to disclose. I will discuss non-FDA approved therapies. I do work as an advisor for Mallinckrodt that's related to sarcoidosis research. As I started the Bernie Mac Sarcoidosis Center at the University of Illinois and the Cold Hand Clinic to take care of patients with scleroderma, with Raynaud's and digital ulcers. But I do not use any Mallinckrodt products for scleroderma care. I will re-emphasize the mission of the Scleroderma Foundation. Patient education is an integral part of the process of the treatment. I think once you know about your disease, you take an active part in the treatment and the management, and that has shown to improve outcome. So I encourage you all to read more about your disease and reach out for resources to educate yourself about your disease, because the scleroderma is such a heterogeneous disease and every patient is different. So the Scleroderma Foundation tries to make life easier for patients who suffer from scleroderma, gives them support, education, and encourages research as well. So it is a very important foundation that I've been honored to work with for the last few years. The objectives of this talk: I will give you an overview about scleroderma. I'll give you a few updates, and we'll talk about some future directions. What is scleroderma? It is a multi-system autoimmune disease that can affect any organ, but most commonly we worry about it when it affects the internal organs, like the lung, the gastrointestinal tract, the heart, and the kidneys. The cause is still unknown. There are many speculations and theories behind the etiology, but we don't know the exact cause of the disease. And the disease is characterized by thickening of the skin that is a result of accumulation of connective tissue and collagen type 1 and type 3. But the more important than skin involvement is the internal organ involvement. The word scleroderma comes from the Greek, meaning thick skin. Early symptoms of the disease often include cold hands, tightening of the skin, changes in the facial features, joint pain, heartburn, shortness of breath, and fatigue. Patient awareness of the disease is very important. It gives a better chance for early intervention, early treatment, and return to normal activities. The message I want to give you today is scleroderma is a treatable disease, regardless which stage you are diagnosed. There are options for every stage of the disease. How do we classify scleroderma? Or the other names used for the disease is systemic sclerosis. So those two terms are used interchangeably, but for the sake of this presentation, I will use the term scleroderma. It can be systemic, and the systemic form can be limited or diffuse, and it can be localized, And there are scleroderma mimics, diseases that look like scleroderma that we need to identify and exclude before we make the diagnosis of scleroderma. So here is scleroderma as a disease. It can be localized or it can be systemic. And the systemic form can be limited, can be diffuse, or we use the term scleroderma, scleroderma, where the patient may present with the gastrointestinal symptoms, problem with their swallowing, heartburn, motility issues, without having any external features in the skin to suggest the disease. And there is the localized form that includes the morphea or the linear scleroderma. When we talk about the systemic disease, this is how the limited disease in terms of skin involvement looks like, and this is how the diffuse disease looks like. When we say diffuse, we refer to the skin thickening. And the skin thickening in the diffuse can involve any part of the body. So it is the proximal and the distal. The proximal meaning the thighs, anything above the knees, and anything proximal to the elbows. And the two areas we focus on, we try to focus on skin thickening on the anterior chest and in the abdominal area, the skin of the abdomen. Because early involvement of the skin in those two areas is important to identify because it will make us look closely for internal organ involvement. The limited disease, the skin involvement does not go beyond the forearms and does not go beyond the mid-thigh. Scleroderma affects young people, but can affect any age. The peak age range is 35 to 50 to 64. The female to male ratio is 3 to 1, so it's mostly a disease of women, but it does affect men. And when it affects men, especially African American men, the prognosis is worse. The incidence is 20 per million per year in the United States, and the prevalence is 240 per million. Again, you'll see me repeat those two terms because the focus is the limited disease and the diffuse disease. Because what you want to decide up front, do I have the limited disease or do I have the diffuse disease? And depending on which one you have, then you will be looking for the complications, what to expect, and the treatment options. So in the limited disease, there is skin thickening distal to the elbows and the knees, and does not involve the trunk. This is important. There is less organ involvement, but isolated pulmonary hypertension may occur and may be the presenting manifestation. In the diffuse disease, the skin thickening occurs proximal to the elbows, knees, and it does involve the trunk. It's more likely to have internal organ involvement. Pulmonary fibrosis and scleroderma renal crisis are common in this form. How about Raynaud's phenomena? Raynaud's phenomena occurs in every form of scleroderma. However, a lot of the referrals I get are patients who have Raynaud's phenomena and a positive anti-nuclear antibody. And they're all scared that they have scleroderma. Not every case with Raynaud's and positive ANA means scleroderma. So we kind of neglect even the titer of the ANA, because a lot of patients focus on the titer. Oh, my titer went from 160 to 2,500. What does that mean? And if I have Raynaud's and a positive ANA, what does that mean? Sometimes nothing will happen. There are a lot of patients who will live with a positive ANA and Raynaud's, as long as they do the precautions needed for Raynaud's, and we screen the heart and we make sure there is no pulmonary hypertension, they do fantastic for years. And if there is no progression after the first 2 years, it's unlikely that progression will happen after that. If the Raynaud's is severe, it may result in ischemia. But the ischemia, we used to see it a while back, years ago, when I used to do this presentation more than 10 years ago, we used to see more ischemia because we did not have many therapies as we have right now, and we did not recognize it as early as we do right now. Heartburn is a major feature, and it is very important to recognize. So in almost every scleroderma patient I see, I send them to gastroenterology for evaluation so that the gastroenterologist will decide and give them a plan. When do they need an endoscopy? When do they need to look for Barrett esophagus or abnormal cells in the esophagus if they have long-term heartburn? And what's the optimal treatment for heartburn? Interstitial lung disease occurs in mostly the diffuse disease and can be severe. And the cause of death usually is progressive lung disease or progressive pulmonary hypertension. This is the limited form that's formerly used to be called CREST syndrome. You can see the Raynaud's features, the calcinosis, and the telangiectasias. Now, Raynaud's phenomena can involve one finger, can involve more than one finger. You may see the 3 color changes, or you may see 1 color changes. It's a normal phenomena when you are exposed to cold for your hands to get cold. But if it takes more than 15 minutes to 20 minutes to warm them back, and if you start getting white fingers that do not go away after 20 minutes, this is significant. It is important to look into carefully. And it is important as well to watch for early digital ulcers and to watch for the tips of the fingers. If there is decreased blood flow, the tips will be cold and they will become flat. If you look at the tips of your fingers, they should be forming a nice bulb. But if there is decreased blood flow with time, even if there are no ulcers, the bulb will become flat. Telangiectasias or red spots are important to recognize for 2 reasons. First, cosmetic. A lot of patients don't like the way their face looks, and it is important when you have a beautiful skin and suddenly it's full of these red spots and you want to cover it with makeup. Yes, there are all kinds of makeup that can cover it, but laser therapy is safe and effective in telangiectasias, and it should be covered by insurance because it's not cosmetic. The telangiectasias are caused by the disease. It can be done more than once, okay? In terms of the other importance of the telangiectasias, if they happen in the skin, we worry about them happening in the internal organs, especially the gastrointestinal tract. So it is important to always look at the hemoglobin to make sure you're not anemic and to look at the iron stores. And if we see the ferritin is low and the hemoglobin is low, we always worry about hidden bleeding from these telangiectasias or dilated blood vessels. They may be bleeding silently. So that's when we recommend that you see a gastroenterologist. How about the systemic form? The systemic form includes diffuse skin involvement in addition to Raynaud's and changes in the facial features, in addition to what we call a salt and pepper appearance of the skin. Now, we should not see that anymore. Years ago, we used to see it, but now I think if you recognize the symptoms early and start treating it early, it will make a difference. It can prevent a lot of these changes. I recall here my former teacher and mentor, Dr. Michael Ellman, who was an authority in scleroderma. And he treated patients for so many years. He established a clinic at University of Chicago. And I recall in the year 2000, I would ask him, what would you use to treat a scleroderma? Is it treatable? At that time, he used to say, you can use any drug, any immunosuppressive drug, as long as you use it early enough and as long as you know how to monitor for it. And I'm looking now from the year 2000 when he said these words, hey, what he said stands true until today. I think if we recognize the disease early and start the treatment early, even if it's not FDA approved, we're able to make a difference. In terms of the manifestations, I will go over these manifestations quickly, and toward the end of my presentation, we'll go back to that slide and talk about updates in the treatment for each manifestation, okay? So Raynaud's phenomena is one, skin thickening, gastrointestinal symptoms, pulmonary symptoms with shortness of breath, cough, and interstitial lung disease, renal symptoms, developing high blood pressure or renal crisis or developing renal failure, systemic symptoms from fatigue to decreased appetite to feeling like you're 100-year-old. You can't get up from the bed in the morning. You feel your life has been taken away. So a lot of these systemic symptoms cannot be neglected because they do impact the quality of life. And musculoskeletal symptoms from terms of myositis, muscle weakness, and arthritis. When we examine patients at bedside, we look at something called skin scoring. And there has been many ways to measure the thickening of skin, from novel techniques using ultrasounds to other techniques to measure the skin thickening. We still do it by the finger. So it's a matter of experience, how many skins you've examined in your lifetime. So you examine every patient, every visit, to see if the skin thickening have changed with time. Skin should be elastic. So you touch the skin, you hold with the two fingers. It should move up and down. So with Raynaud's and sclerodactyly, sometimes this is not as elastic as it should be. And that should be both in the fingers and in the forearm and in the face and the rest of the body. So we look at different areas of the body and we give each one a score and we try to monitor the disease this way. Why this is important? Because from studies done in scleroderma, over time, if you look at the skin score and you look at certain antibodies that may predict which patient may progress, you can see that I will not focus much on those antibodies, but even if you look at the SCL70, which is the one that occurs in patients with lung involvement, it is in green. If you look at this line in green, if the diseases start here at year 1, it peaks at 2 years, and then the skin starts to soften. But even when the skin softens, it changes your facial features. You look at your old pictures, you don't look the same. So our goal from treating diffuse disease now is to get patients early on when they are the beginning of skin thickening. So we try to prevent worsening. Now, there is a big debate. If there is only skin involvement, would you treat the skin or would you wait for internal organ involvement? And there hasn't been large-scale comparative studies to give us an answer about this. In addition to the physical exam, we check antibodies in the blood. Not all centers check all antibodies. Most centers will check anti-nuclear antibody, and they will tell you if you have a centromere or nuclear antibody, and other centers may check other more sophisticated antibodies. So you get the anti-nuclear antibody and the anti-topoisomerase, or the SCL70. Those are the two commonest antibodies that are checked in most centers and most labs, whether you go to Quest or any other lab at your institution. Other antibodies could be a send-out test, include RNA polymerase 3, U1-RNP, PMSTL, T0, and these antibodies are done at specific centers. And those antibodies has been linked to muscle involvement, lung fibrosis, overlap syndrome, pulmonary hypertension, or renal scleroderma renal crisis. Now, these antibodies are expensive, so it depends if they're done based on research basis or if your insurance will pay for them. So you don't have to worry about checking them, because I think after all what matters is the bedside exam and what your physician thinks about your case. So if you can't afford checking all these antibodies, it's okay just to be satisfied with the ANA and the SCL70. Skip this slide. Okay. Diagnostic criteria. The slide I skipped is exactly the same antibodies, but it's put in a different format. And just to give you an idea what antibodies are done for which phenotype of the disease. And I mean by phenotype, lung involvement is one phenotype, which is the lung phenotype. Raynaud's is one phenotype, the vascular phenotype. Pulmonary hypertension is one phenotype, which is the vascular phenotype. In 2013, there were some new diagnostic criteria for scleroderma. In 1980, there were older criteria. So in order to detect the disease earlier, the American College of Rheumatology came up with some diagnostic criteria. And I will not go over these criteria. You have them in your handouts. That's what we use as physicians when we make the diagnosis. And oftentimes, the criteria are used for clinical trials. Again, the criteria are not set in stone because, as I said, every patient is different. So you may have two criteria. You may have skin thickening and fingertip ulcers. But you may not have telangiectasias or nail fold capillary changes. You see us when we do the exam, we use a capillaroscope. We hold every finger and we try to look under the microscope to see if there are dilated blood vessels under the nail bed. And that's one of the key tests that we do in some patients with the vascular form of the disease. So some patients may have some criteria early on, and other criteria may evolve as the disease progresses. So you have the list of criteria just for a reference. What are the challenges we face with scleroderma for you as a patient and for us as physicians? While there is no cure for scleroderma, I believe there is great hope. You should never lose hope that you can improve your quality of life and get better. That's crucial as the first step of treatment. With early intervention, it is often possible and very possible to manage the symptoms and offer a lifetime of hope. With early the diagnosis, the earlier the diagnosis, the earlier you could be offered treatment, whether it's a standard treatment or whether it's a treatment based in clinical trials. Scleroderma can happen in men, can happen in older people, and it is a life-changing disease. It's one of the orphan diseases that can change your life. Life is tough as such with dealing with challenges of daily life, just dealing with life in general. Life is not an easy ride. How come if you add another disease like scleroderma, it becomes extremely difficult? So you need a lot of support around you. Support from family, friends, foundations, as well as your physician. Scleroderma continues to be challenging for us as physicians because every patient is different. And trust me, when we see the patient, we think a million times, what would be the best drug? Is this patient a candidate for stem cell transplant? Is this patient a candidate for chemotherapy? How should we treat to prevent further complications without giving the patient another disease from the medications we use? So with all the research that's going on, I do hope that we are on our way of, even if it's not a cure, of disease-modifying medications that will alter the quality of life. Cardiac involvement is a major issue in this disease, and my colleague, Dr. Patel, who taught me a lot more than I taught him, I guess. We worked together at University of Chicago. He leads the, he's a great, one of the great cardiologists over there with an interest in both sarcoidosis and scleroderma. And he will give you a talk about cardiac disease and scleroderma. So I will not talk about cardiac disease. I just put this slide for your reference to list the cardiac involvement in scleroderma and what are the things we look for So as rheumatologists, when we meet a patient, screening for the heart is crucial. By physical exam, I'm still a big fan of physical exam, we can tell if there is early pulmonary hypertension. We listen to the heart sounds carefully. And that is an important way of diagnosing pulmonary hypertension, but it still does not mean if you don't hear anything abnormal with the heart exam that you should not do an ultrasound of the heart. And in some patients, you may do the $1 million workup and they're still short of breath. So exercise-induced pulmonary hypertension is an under-recognized entity, and many centers don't do the exercise pulmonary hypertension test. Let me, some of the slides I put just for your reference. If you have questions about them, I'll answer them in the break. But I will go over some great outcome cases to give you some hope. Then we'll talk about a few updates. This slide shows the digital ischemia and how the Raynaud's may look like, and how when we do an angiogram, the blood vessels may look like. This slide, thanks for the patient who agreed to share their pictures, their hand pictures in this slide. Some of the complications you may see long-term with shortening of the digits and contractures. Again, if we diagnose the disease very early, we should not reach to that stage. But hand involvement continues to be one of the major challenging issues of the disease. Fingertip ulcers, contractures. And if you know that you have Raynaud's, it's important to avoid cold. And there are many medications we could offer for Raynaud's. I'll come to that in the final slide. Let me skip those slides because I know Dr. Zachary will talk about these medications for the treatment of Raynaud's. This slide lists all the medicines we could use to improve the outcome in patients with Raynaud's. Let me skip this slide for the sake of time so we'll have some time for the update. Now this is one of the patients I took care of in 2004. And we had no medications to give at that time. Our main option at that time was calcium channel blockers, angiotensin-converting enzyme inhibitors. But then Dr. Zachary, for this case, did digital sympathectomy. He's one of the surgeons that dedicated his life to care for patients with scleroderma. I think he's the one who saved hands and fingers more than anybody in the world. So in this case, after surgery, you can see the complete healing of the fingers. And that surgery was done, I think, in 2003, 2004, and the patient continued to do well after that. Dr. Zachary is an authority in the Fanta Transfer. He will explain his technique to you today, although it's not FDA approved and research-based. He takes some fat from around the stomach area and injects it in the hand or the foot that is cold. And here you can see the change after he injects the fat. And the beauty of this is that the fat cells may change into different type of cells when he puts them in the hand or the feet, and they start growing blood vessels, and they improve blood flow. I want to share this case with you because this is a young man with scleroderma. We often talk about men, but he lost his job because he could not continue to work. He was working in the cold. He did not have any heart disease or lung disease, but the limiting factor was his hands. So you can see how his hands looked like when I saw him. Now, we could not give a referral to see Dr. Zachary or to see a surgeon where we can do Botox injection or do Fanta Transfer. So this is one of the cases that I've used only medical therapy and topical wound treatment. Again, all off-label. So this was 4 years ago, and this was recently. You can see the complete healing. But in this case, we've used Viagra plus a low-dose prednisone, and we used a low-dose Cellcept or mycophenolate plus aspirin. So it's a combination of medications that helped restore the blood flow and heal the ulcers. So I presented this case to show you that this patient, despite the lack of insurance that allowed him to see plastic surgery, with medical treatment alone, we were able to improve the flow and result in complete healing. And I think that gives a great hope. It gave me certainly a great hope even for treating pulmonary hypertension, because this is within the same realm of vascular disease. Last year I presented to you that we started a technique using MRI, magnetic resonance imaging, but this technique is called NOVA. NOVA is an MRI software that's very expensive, available only in few places. I'm fortunate that it's available at the University of Illinois. Dr. Fadi Sharbil, the chief of neurosurgery, is an authority in this area. And he uses this technique to image the vessels in the brain to determine the risk of stroke. So this is a technique used to determine the blood flow to the brain if you are somebody who had stroke before. Cardiologists and cardiac surgeons sometimes may use this to look at the blood flow in the arteries that go to the heart. And in some centers, they may use this technique for the kidney. So we thought about using this technique to measure the blood flow in the hand. Why did we think about this technique? Because MRI, while it's a great test to screen the heart early on, it involves dye, the gadolinium. Now, years ago, in 2004, 2005, we found that gadolinium can cause skin thickening and can cause a disease called nephrogenic systemic fibrosis, a disease similar to scleroderma. Not all forms of gadolinium can cause that, okay? So they change the type of gadolinium they use, and that decreases the risk. But more recently, there is some concerns about gadolinium in children. So this technique does not involve gadolinium. It's a software that measures the velocity of the blood flow, and it's still preliminary, but we were able to measure the blood flow in the vessels in the hand, in normal people as well as scleroderma patients. And even in the patients where we found the ulcers has healed, we were able to show that there is still a cut of blood flow. The blood flow did not improve. So this is a preliminary research. We got short of the funding, so we did not complete the study yet, and the preliminary data are not published. But I think this is a great hope to have a baseline where we can measure blood flow, not only in the hands, but in other parts of the body. I have 5 more minutes?
5 or 10, yeah.
Okay. So before I go to the conclusion, let me go back to the slide to talk about the update. Give me a second to try to... And I can go over the conclusion from that slide. Okay, so I promised to go over every manifestation and give you an update what's out there for every manifestation of the disease. We start with Raynaud's phenomenon. Raynaud's, I've already told you that we are in the process of having a new way of measuring the blood flow to the hand. There are many ways out there to measure the blood flow, but I think it's crucial to measure it in an objective way so we can tell which finger is at risk of ulcer in the future. And the old saying would say the eyes are the windows to the soul. I think the digital arteries are the windows to the heart, because a lot of times what we find in the hand, it may be a reflection of what's going on in the heart. And the medications we use to treat pulmonary hypertension help with the Raynaud's symptoms. Very important if you have Raynaud's, regardless what stage of Raynaud's, is to protect your hands from cold. More colds, meaning more Raynaud's, it begets more ulcers and more cold hands. So wearing mittens, if you want to use heated gloves, don't put your hand in the freezer without having gloves on, don't cut the meat when it's frozen, don't hold a can of soda. All these are important. So taking care of your hands is important. It's not whether you live in Chicago or you live in Arizona, it's the change in temperature that affects patients. In terms of medications, you can use one or a combination, and there is not a single one that gives you 100% improvement. From topical nitroglycerin to topical deltiazem. There are clinical trials on clinicaltrials.gov that talk about this, to Viagra and related drugs. And in advanced cases, we use epiprostinol, which is a drug for pulmonary hypertension. From the surgical management that Dr. Zachary will talk to you about. Sometimes we use all these techniques together. Every patient is different. So I can't tell you there is one drug that works for Raynaud's. But Raynaud's is not very difficult to treat, and the outcome is great in treating Raynaud's, even if the patients present with ulcers, okay? Calcium deposits are the hardest to treat, but they can be removed surgically or with bisphosphonates may improve the outcome. How about the skin? The earlier you discover the skin, there are two groups of thoughts. Either leave it until maybe it gets thinner by itself, if there is no internal organ involvement. My approach tends to be to start early treatment. I give a low-dose corticosteroids or a low-dose methotrexate, low-dose Immuran, low-dose Celsep, depending on the case. And exercise, physical therapy is crucial. Gastrointestinal, our great Dr. Brown, we're honored that he's been joining us for the last couple of years as well and dedicated to serve patients. He's amazing. Patients get great care, and I think he'll talk to you about the gastrointestinal manifestations. What advanced things we have right now, there hasn't been a discovery of one magic drug that will help the motility or fix the gut involvement in scleroderma, but with diet, with some medications to control heartburn, some motility medications, treatment of bacterial overgrowth, there is improvement in the quality of life. I'll give you an update on the one case where we did a small intestinal transplant in the advanced cases where the patient lost all her gut. With a small intestinal transplant from her daughter, she's doing fabulous after 4 years of transplant. She's back to dancing, her skin is better, she doesn't have any features related to scleroderma, and she's eating okay. So I think small intestinal transplant is an option in the future. How about the heart? Dr. Patel will talk about the heart in terms of medications probably to fix the heart function, but my role as a rheumatologist, if there is heart involvement, immunosuppressive therapy is a must. The question is, which one would you pick? Whether it's azathioprine or mycophenolate or Cytoxan, it depends on the case. So it's important to get a baseline echo, and if you have fluid around the heart, pericardial effusion, you need to talk to your rheumatologist to start treatment early. Lung involvement. We had multiple clinical trials over the years for lung involvement. What is the update out there that's published? To start cyclophosphamide as an induction therapy in patients who can tolerate it for lung disease. In those who cannot tolerate it, then you can use mycophenolate and you can use azathioprine. But if you use cyclophosphamide as the first agent induction, meaning IV or oral, then you can follow that by by azathioprine or mycophenolate. But it's important to decide, does your lung involvement needs to be treated? If it is advanced and fibrotic, then your option is lung transplant. And Loyola, they do a great job with transplanting scleroderma patients, even if they have dilated esophagus. They have some good results with that. But if there is active inflammation, then it's important to treat it early on. Renal disease, it's important to check your blood pressure 3 times a week at home. If the blood pressure goes up, it's important to talk to your doctor. There is no role of using prophylactic blood pressure medications to prevent this phenomena, where what we mean by renal crisis, blood pressure goes up, renal failure may happen, and the outcome is bad. But even if it happens, you need to go to the emergency room, get treated with IV medications, ACE inhibitors, and oftentimes there is recovery. And sometimes we add immunosuppressive drugs. Myositis and arthritis, it tends to respond to methotrexate, and myositis to IVIG. Systemic symptoms, dietary modifications, and I keep repeating, keeping the hope and a positive attitude plays a major role. Now, if you want all the clinical trials This, what I discussed with you, is what's out there and considered standard right now. But if you go to clinicaltrials.gov and put any manifestations you have, if you're interested in calcinosis, myositis related to scleroderma, there will be a list of clinical trials and the centers participating in these clinical trials. I believe the foundation lists sometimes the clinical trials. I'm not sure if you list any active clinical trials yet, but you may go to clinicaltrials.gov. I think that will be a great resource for you if you're interested in clinical trials. So, in conclusion, scleroderma is a systemic autoimmune disease that affects multiple organs. It can be two forms, the limited disease and the diffuse disease. In the limited disease, it's mostly Raynaud's and pulmonary hypertension. In the diffuse disease, it's mostly skin involvement, lung, and heart involvement. In both forms, you will get Raynaud's and you will get gastrointestinal involvement. The outcome is variable, but there is a great hope to improve quality of life and treat the symptoms with early diagnosis. So my concluding statement is, regardless what stage of disease you have, there is always hope. And we're here for you to help you and support you with any way we can. Thank you so much.